Good afternoon. We are ready to start, and welcome to this session, The Turning Point in Hypertension Care, Symplicity Spyral, renal denervation in Practice. It's a pleasure for me to share this next 60 minutes with you and my colleagues and friend, Professor Rasha Alami from London, Professor Andrew Sharp, Professor Ronald Smider, and Dr. Valérie Duchatel, Professor Valérie Duchatel. We don't make difference, huh? Yeah, well, all professors. Hello, Stefan. So you are here because you want to know the upgraded recommendations of renal denervation for hypertension in the latest guidance. Indeed, last year, the European Society of Hypertension considered the treatment with renal denervation for a series of populations that were not indicated before these updated guidelines. And Professor Smider will talk on that. The second point why you are here is to understand how to perform a safe and effective renal denervation. This is a very practical presentation by Andrew. He will tell you how to do the procedure, and then to learn how to set up a renal denervation program and partner with referring physicians on patient selection. Probably the most demanding and difficult part to get patients in a healthy renal denervation program. Before we start, I will ask Rasha. You can do it. I can advance the slide for you.
No, it's perfect. So thank you very much. It's an absolute pleasure to join you all this evening. I guess the main point we'd like to make is we want to make this whole session as interactive as possible. So please feel free to ask questions by going up to the mics or ask questions through the PCR app. And I'm here with the laptop and I will try and field all of your questions to the panelists. And importantly, it's an important day today because it's the Worldwide Hypertension Day. And as is kind of tradition for Medtronic, what we'd very much like is for all of you to get out your mobile phones, scan that QR code, and just give it one click. And just one click of a like will suddenly mean that the company are forced to pay and contribute to changing cardiovascular health care outcomes, and in particular in our patients with hypertension.
Thank you, Rasha. Hope you have taken the picture. Information is given. We are ready to start, and it's my pleasure to call Professor Smider to talk about the guidelines.
Thank you, Flavio. Distinguished audience, it's now my pleasure to give you an update on the guidelines. I will not talk about the FDA approval of the renal denervation catheter. I think it's important also to have the opinion of various expert groups, and they are reflected in the guidelines. This is my conflict of interest. And actually, when I had to give the talk 6 years ago, well, it wouldn't be so many guidelines that have been published in the meantime. You can see here the long list of guidelines sorted by years. And also in 2024, we are expecting new guidelines from the European Society of Cardiology and also from the American American Cardiac Societies. Both of them will also have a statement this year. So let me start where the journey starts with respect to guidelines. 6 years ago, 2018, there was this sentence that the device-based therapies is not recommended for the routine treatment and hypertension unless in the context of clinical studies until further evidence regarding their safety and efficacy becomes available. And clearly this is now available and also acknowledged by the FDA, as I already mentioned. There have been various position papers, and in 2023, we have the new guidelines from the European Society of Hypertension, and there you can read the following. Renal denervation can be considered as a treatment option in patients with uncontrolled hypertension, with uncontrolled blood pressure, despite the use of antihypertensive drug combinations, or if drug treatment elicits serious side effects and poor quality of life. It is specifically stated later on that this RDN is considered as an additional treatment option in patients with resistant hypertension. But also, it's not a necessity that there must be a resistant hypertension, that renal denervation can be applied in hypertensive patients who are not at target blood pressure. And this process, of course, then requires, if you are in that range, a shared decision-making process with the patient. This is also clearly mentioned and specified in the guidelines, and this renal denervation should be performed in experienced centers to guarantee appropriate selection of eligible patients. I think that's the cornerstone of the new guidelines of the European Society of Hypertension with respect to renal denervation. And when you look at the scheme for blood pressure-lowering therapy in true resistant hypertension, you can see here also on the lower left part, renal denervation is an option. It is an option after we have a 3-drug combination of an ACE or an ARB, CCB, and a diuretic, preferentially in a single pill combination. And then we have to think about what is the best for our patient. Is it another drug? How well is it tolerated? What's the personal history? Or is renal denervation an option for this patient? On the left side, if eGFR is below 30, it's not listed, simple, because we have not so large evidence as for patients with an eGFR above 30. And let me just go back. Sorry, now that's okay. And the evidence we have achieved so far comes from several, actually 6 randomized controlled clinical trials, sham-controlled clinical trials. That's the point. Here you see these trials on the left 7, the publications in patients off therapy. On the right one in hedge bears, the 3 ones with therapy. And as you can see also, if you have a new therapy, you can see there is a substantial change in blood pressure, a decrease of roughly in office blood pressure, roughly about 10 mmHg. And on top you can see the numbers, a significant difference versus a sham group. And this is the highest scientific evidence we have, clear fall of blood pressure. It does not reflect what is going on in the real world. We come to that later on. But from a scientific perspective, this is pure scientific evidence. Renal denervation works as we have imagined some years ago. And here, a 24-hour profile. On the left side, renal denervation, you can see the whole curve is lowered by approximately 5 to 7 to 50 mmHg, depending on the baseline blood pressure. But what is important also in the early morning, when we have a rise in blood pressure, a rise in heart rate, we have the highest incidence of cardiovascular events. There, blood pressure is well controlled. On the right side, the sham control just as a control group. Now, we call this as an always-on effect, but it's only half of the truth. Always-on means also once we have performed renal denervation, this effect is always on over days, or weeks, months, over years. Once done, it's done. It's not dependent on an every morning pill intake. And that's a big advantage of renal denervation in comparison to drug therapy. Safety? Well, nothing real to say. You see here's this slide here on the left side. You'll read no new evidence of renal arteriosclerosis at 6 months. I can also tell you at 12 months, there is no signal that renal denervation harms the renal artery or, as indicated on the right side, changes or harms renal function. It is well preserved over 3 years, and therefore we have no safety signal. That's a big advantage. We have a device therapy with no safety signals related to the procedure per se. Does it work in various groups? Now here you can see the results from the Global Symplicity Registry, and this is now real-world evidence. Resistant hypertension on the left column, minus 23.5 years after 3 years. Then you can read it works in diabetic, it works in patients with atrial fibrillation, it works in patients with chronic kidney disease, isolated systolic hypertension, also in older persons, and also in patients after MI or stroke. So at the moment, we can say it works to a various extent. We do not know whether it's a chance finding or not, but it works in all patients to a significant, clinically significant way in terms of blood pressure reduction. This is a very nice meta-analysis which has been presented at the American College of Cardiology some weeks ago. And you can see here a summary of 18 independent reports, over 4,400 patients included, with a mean follow-up of 4.4 years. Some have a follow-up up to 9 years even. Office systolic blood pressure reduction, you can see on the right side, the meta-analysis here is minus 23.2 mmHg. When the GSR, which is a dominant contributor to this analysis, is included. But even if we take that out of the GSR, just take all the other studies where radiofrequency renal denervation has been performed, you can see here a decrease by 24 mmHg. Diastolic, by the way, minus 10 mmHg. And ambulatory blood pressure was minus 14 over 10 mmHg, reduced after 4.4 years as well. So I think these numbers are clear worlds and reflect the real world situation that you can expect. So finally, where are we? Well, 23, we need another column now for 2024. We will do that at the end of this year. I'm sure we have maybe two columns. Let's see how many guidelines come out. But I want to stress 2 points here. If you look at these guidelines, there is a uniform consensus that resistant hypertension, here renal denervation, is a treatment option. Next, if there is an intolerance to drugs, also what you can see here is all guidelines express this as an option to be considered with a patient where the renal denervation is not the right treatment for his hypertensive disease. And likewise, you see in most of the guidelines uncontrolled hypertension, and when this you have a cross here, you always have a cross here at patient preference. So clearly, when you have uncontrolled hypertension, patient 1 or 2 drugs, not controlled, maybe intolerant, or said, I don't like drugs so much, do we have another option? The patient needs to be taken into account, this patient preference, and then you may come to a common decision whether renal denervation is the right option for him. With that, I would like to thank you.
Thank you, Roland. Thank you very much. You have said all what we need to know before considering the therapy. Now I will invite Professor Andrew Sharp to show how the procedure is performed, and then we will dedicate 10 minutes for discussion. And we encourage you to make questions. I mean, the questions you write through the app will be written here, and we'll try to reply.
Okay, thanks, Flavio, and thanks for the invite. Those are my conflicts. Okay, so what is the aim of renal denervation? It is to disrupt the renal sympathetic nerves that connect the brain to the kidney and the kidney to the brain. So it's a two-way process. And we aim to do that by heating the fat that sits around the renal artery, and within that fat sits the renal sympathetic nerves. We need to raise the temperature of the fat without damaging the arterial wall to the point whereby the nerves are ablated. And that disrupts communication both ways between the kidney and the brain. So we have sham-controlled trials now showing very low complication rates, less than 1% of serious complications, across multiple trials with even multiple devices. And the RF system has treated more than 25,000 patients worldwide. So there comes a threshold with devices beyond which, if there's going to be any surprises, they would pop out. And that's usually around 10, 20,000 devices. So I think if there's any surprises, now we begin to see it. We've got 10-year follow-up, and we haven't seen anything unusual. It seems remarkably safe. Whoops. So how does it work? Well, it's a 6 French compatible device, and it's on a nitinol catheter with some gold electrodes. 4 gold electrodes arranged in a retrograde spiral, so that when you deliver energy, you deliver north, south, east, and west on the artery, but you do it in a staggered fashion. It's connected to a generator, and you put a wire into the renal artery, a support wire that's usually uncoated. We don't want any slippy wires sliding in and out of the renal parenchyma. And then you deliver this device. It doesn't need that much action or skill to deliver. And it will deliver like a microcatheter flat over the wire. And then when you pull the wire back, it springs into this shape. It'll treat all vessels between 3 and 8 millimeters. If you try and treat vessels below 3 millimeters, the generator will typically just cut out. So the generator that controls the system is not a dumb system, it's a very clever system. And its job is to try and keep the temperature within a certain range, typically 55 to 65 degrees. And then it will continuously modulate energy and control of the system in order to make sure it delivers the right amount of energy to give a safe and effective delivery of RF into the periadventitial fat where the renal sympathetic nerves are. As I say, 6 French compatible, and it goes over a coronary guide wire. It plugs in quite easily, and it can be controlled from the bed, which I'll show you in a second. And it relies on blood flow. So it's not just a strength that it has blood flow, it relies on it, because the reason it's so safe is that the blood running at 36 degrees in all of our bodies will cool the endothelium during the energy delivery, but the further away the energy is targeted, the further away it is from the cooling blood. So the area outside the artery heats up, but the wall of the artery is kept relatively cool, and that's how it recovers completely. So it's designed to give this cloud of energy across multiple points in multiple directions at the same time. And in the trials, it was about 11 energy deliveries between the two sides to give a very comprehensive denervation of the renal arterial tree. So how do we target that energy? We've learned a lot since 10 years ago. We used to have this single point catheter that was a bit like an old EP catheter. And we used to have to draw north, south, east, west, and we'd maybe try and do it twice within a main renal artery. But in reality, operators found that difficult. The redesign with the Spyral system delivers 4 automatically, and it's highly flexible. That allows it to go beyond the bifurcation and into the branches. So we never want to deliver energy inside the shadow of the renal parenchyma. We want to stay outside of that. But as you can see from this anatomical prosection, it turns out that renal nerve anatomy is highly complex. And although it's been studied since the time of ancient Egypt, and Leonardo da Vinci drew paintings of renal anatomy and its surrounding structures, we've learned a lot more in the last 10 years about the structure. And sometimes nerves come from far away and only wrap around the vessel beyond its bifurcation. And therefore, the calibration of the device that makes it so safe is designed to deliver that energy to a depth where the branch arteries are really in close approximation to the nerves, and therefore it's easier to access those nerves around the bifurcation and beyond. So what you see in the image on the right, a dot is where a nerve is, and all you can see in the left, after the bifurcation of the main renal artery, how tightly wrapped those nerves are around the artery, and therefore you can give this low dose of RF and safely ablate them. Proximally, the nerves go further away, and so in the days of the early field of RF, we were occasionally potentially missing some of these outer nerves. But now that we've changed the strategy to deliver around the bifurcation, first order branches and the main, we're getting them very comprehensively. This is demonstrated in a preclinical model where if you just do the main artery, you can see the 3 boxes on the right-hand side of the screen. The pink one is if you just do the main, and the neurotransmitter, norepinephrine, which is the sympathetic nervous system neurotransmitter, you do reduce it, and you reduce it by 70%. If you go into the branches where these nerves are tightly wrapped, then you reduce it 83%. And if you do both, you get the best of both worlds and you get a 91% reduction. So a comprehensive reduction in renal sympathetic nerve activity. This is what it looks like inside a human cadaver on the left. And if humans were made of gel, this is what it would look like in the middle. You'd heat it and you'd very gradually get this alteration of the tissue characteristics around it. But humans aren't made of gel. So what you get is the image on the right, the baby Elvis, which is energy goes into the fat and it will flow until it dissipates. So it may run into the borders of surrounding structures, whether they be lymph nodes, like those purple structures, whether it's the renal vein, which is a high flow system. And if the energy goes near the renal vein, it'll just be carried away. It's like trying to fire a water pistol into a river. It'll just get carried straight away. And then it will flow around through the fat like water running down a riverbed. And so you don't get this simple hemicircles like you get in the middle. You get this more complex structure. But that has its strengths because it means you can deliver just the right amount of energy to try and take out those red circled sympathetic nerves. And we've done animal testing showing at day 7 and day 180 that the brown stain is for tyrosine hydroxylase, which is the enzyme that creates the neurotransmitter of the sympathetic nervous system. So when it's intact, you get brown. When it's been denervated, you get no brown. And so on the right, we found that if you were able to target it properly and comprehensively at the original procedure, it stayed absent, and therefore there's no ability for any remaining structure within the distal nerve to be able to manufacture sympathetic nervous system transmitter. So if we get it, we've got it. So renal anatomy assessment, how do we do it? You don't need to do pre-procedural imaging, but if it happens to be there, look for the arteries. About 1 in 3 people will have an accessory artery. You want to know if that's there, more than one artery to an individual kidney. If you're doing this invasively, you do an aortogram. You put your pigtail catheter up to the junction of L1 and L2, and then you take an aortogram. I do it with 50-50 dilution of contrast, 40 mils at 10 mils per second. So it takes 4 seconds to run the aortogram. And then I can if I'm on a small image intensifier in my coronary lab, I can then move from side to side and see how many arteries there are to each kidney. That then tells me where to look with my guiding catheter. We use heparin, nitroglycerin, and occasionally might need atropine. It's very rare if patients have a bradycardia. And when we deliver the energy, it creates a sensation of heat in the flank of the patient. So you need to give them a little bit of sedation with usually midazolam and fentanyl is what I use, but you use what is appropriate for your patients. The generator is then tracking impedance, which is these numbers 269, 272. And then the impedance will change and it will go down, and then the temperature will go up. And that's a sign that the electrode is in contact. You can see there's 4 electrodes here that can be controlled individually on the bed. So if the patient moves and you lose contact with one of the electrodes, you can go back again, turn one off, and redo it again. And that's the idea of what it's going to do. So this is a very abridged case. So how do we get in? We do ultrasound-guided access. And we aim for the bottom third of the femoral head. So if we accidentally go high, we're safe. We confirm that we're compressible before we give heparin. If you're over the femoral head, you're compressible. You use a non-coated supportive wire, and you guide it not too peripherally, and that wire needs to stay in the screen the whole time. Don't have it disappeared off the end, because then you don't know whether there's any risk of perforation. Here we have the catheter sliding on. You can see it slides on very easily. There's a tendency for the wire to try and go forward, so you put backwards traction on the wire as you're delivering it. Then, when you're happy with your position, you bring the wire back proximal to the electrodes, and then you put a bit of gentle torque on the catheter, and then check where you are. Make sure you're not against any bifurcations. Make sure you're not in a vessel that's too small. It needs to be between 3 and 8 millimeters. And then you deliver energy, and you go across the branches of the vessels, switch to the other side, finish the job, and then go for a cup of tea. So it takes, in the real world, depending on how many branches you've got, it takes anything from 40 minutes to about 65 minutes. If you've got 2 accessories, you might need to go a bit longer. If you've got 2 simple arteries with single bifurcations, it's a piece of cake. So one size catheter fits all, 6 French compatible. Make sure you use a closure device if that's your usual practice. It probably reduces the risk of any growing complications. And this multi-electrode helical design means a total of about 11 energy sets between the 2 arteries. And therefore, you can get this done in a reasonably efficient time. It's based on a very extensive preclinical program, and we've now got over 25,000 patients in the world who've had this. I think if there were surprises, we'd know them by now. We keep doing research. We keep following up. We've got 10-year maintenance of blood pressure lowering, and it looks like it's a highly safe procedure, which is why it's in the guidelines. Thanks.
Thank you very much, Andrew. So yes, please come and join us for the discussion. So we want to warm up the room a little bit. This is 10 minutes now in which we've got time for discussion. We have some questions coming on the app, which is fantastic. If anyone is brave enough, please go to the mics and stand up and introduce yourself and ask questions. But I'm going to start by asking you to raise your hands. So who in the room is already performing renal denervation in their clinical practice? Okay, I'm going to count about 20. Okay. And who is here because they would like to perform renal denervation in their clinical practice? They want to set up a service. Very interesting. Fantastic. Great. So that starts the conversation. And maybe it starts first, a question that keeps coming through on the app. I'm going to give to Andrew, if that's okay.
Yep.
It's about, as you're doing the procedure, how do you procedurally maybe evaluate response acutely, and then importantly, are there particular patients that are responders?
So when you have your arterial tree, you want to make sure you denervate everything. In fact, I'll use the board. Can I take a microphone? So just take me a second. Okay, so if you've got your arterial tree like this, and then you have your renal shadow, your job is to stay outside of here. With RF, we want to denervate 4 poles, so single energy delivery, in each of the branches between 3 and 8, outside of the renal parenchyma. If one of your electrodes is here, you turn it off. Dead easy. Don't deliver energy inside the shadow. Then you do as much as you can. Maybe you do a 4 and then a 2, and you might turn off the electrodes proximally or distally to make sure you're still in the artery. Once you've comprehensively denervated in that fashion, there's a more than 91% predicted reduction in the renal neurotransmitter norepinephrine. So it's highly unlikely that those nerves are going to be able to conduct again in the future. So whilst we have studied a more focused ablation strategy, because we know the nerves are tightly wrapped around here, in the clinical trials that were positive, We did each of the branches between 3 and 8, and that's the technique we showed to be safe. So whilst there's work going on confirming nerve interruption, we know that the chances are so high if you're able to deliver this technique that you're okay. If you have an accessory that's 4 and you miss it, you might miss a chunk of kidney here, and therefore you might leave some nerves behind, and you may have an incomplete response. We showed that with the flex, that if you couldn't get into these branches, then you had a lower chance of success. But the spiral can go anywhere now between 3 and 8, and therefore it's able to give a high degree of confidence that you've ablated. After that, non-response is a mixed etiology.
Thank you, Andrew. That's fantastic. And so the next question, if it's okay, I'd like to bring to Roland. Roland, can you tell us about cardiovascular outcomes? What do we expect? You gave us lots of data to see with patients. I know you gave us some of this data, but will there ever be a trial of renal denervation with the endpoint of cardiovascular outcomes, or can we just extrapolate hypertension improvement and that's enough?
Well, I think that's always a question which is coming up, but let me clearly say even the authorities, but also the expert groups agree that blood pressure reduction is a valid biomarker for reducing cardiovascular events. To give you a number, if you have 10 mmHg less systolic blood pressure, you have, according to a huge meta-analysis, there are 3 out actually, you have approximately 20% reduction of MACE. You have reduction of 28% of development of heart failure and 27% of stroke. Now, these are the data, outcome data, meaning a hard endpoint trial is simply not feasible because you have to have a patient 5 years on a different drug regimen or whatever with some complications. It is more a strategical trial, and this will not happen. But what you know, and I think this is one thing for clinical practices, we know that left ventricular hypertrophy is significantly reduced, a very good marker for cardiovascular outcome. We also know that albuminuria is reduced, also a valid cardiovascular, not only renal, but also cardiovascular marker.
That's fantastic. Great. Yes, if you could, is there a possibility? Oh, we can give you the mic. Perfect. No, this is great. Thank you.
Sorry. At the beginning of the procedure, back more than 10 years ago, the indication was a patient had to take at least 3, preferentially 4 drugs, and a systolic pressure more than 160. The procedure was buried in the States. Let's talk really how it happens. And now it's resuscitated. So what's the indication today? 160 or pressure over 160 or pressure over 140? Because I've been in some talks that they say more than 140.
Yeah, I think this was the Symplicity 3 trial, and at that time they were very cautious to say we want to have above 160. Now, with the new trials, meaning sham-controlled, well-conducted trials, we have a different threshold, and this threshold is the same like in the guidelines, meaning resistant hypertension above 140 is the definition, and confirmed, and that's the point, by 24-hour ambulatory blood pressure, that it's another white coat effect or something like that. So this is the strongest indication, and if you have seen maybe on my slides, there have been 4 studies, and they are, let's say, pushed by the FDA to say, we want to know what is a blood pressure lowering effect if no drug is there. Like if you have a new drug, and this has happened, this was done in 4 studies and came out, we have a clear-cut significant reduction like with a drug.
That's fantastic. And we have 2 questions in the room. The first one at the front. Yeah.
Hi. Professor, you said that you don't use previous imaging. So in case you find renal artery stenosis, would you treat the stenosis first and then do the procedure? What would you do?
Yeah, I may have misspoken. So if there is pre-procedural imaging, then always look at it and work out what your anatomy is. Make sure that there's no renal artery stenosis, fibromuscular dysplasia. Make sure there's no renal artery aneurysms, weird and wonderful stuff like this. But if you don't have the pre-procedural imaging, then the only indication for pre-procedural imaging is to exclude a pathology as part of a resistant hypertension workup. So the guidelines say if you're under the age of 40, 35, depending upon which guidelines, you should investigate for all things like hyperaldosteronism, like renal artery stenosis, fibromuscular dysplasia. So they're going to get imaged somehow. That might be duplex ultrasound, which doesn't guide your procedure. It might be MRA or it might be CTA, in which case it can guide your procedure. If someone has resistant hypertension, we should look for renal artery stenosis again. It might be atherosclerosis in a 65-year-old. But the key is that we don't ask you to do pre-procedural imaging in order to take your patient to the cath lab, because we're going to get an aortogram which is going to tell us. It's useful if you have it, but you don't have to do it. And in the Spyral program, we didn't do it pre-procedure. We imaged them on the table. Does that explain it?
Thank you, Andrew. The
Only
question on the
for
floor.
practice, I made only 4 denervation, and I noticed that it's really painful for the patient. After the first 2, I called for the anesthesia and then deep sedation. Really painful.
Maybe Flavio, would you comment?
Yeah, I mean, you should have known that before. It's very painful. If you have the anesthesiologist in the room, this is a luxurious situation, and it's the ideal situation. It's very deep sedation. It's not even conscious. It's better to be unconscious sedation, much more than a TAVI procedure. If you don't have the anesthesiologist and you are used to deal with drugs, you can do that. I mean, we don't have the anesthesiologist, but we go very, very hard with sedation and analgesic drugs. That's absolutely, and this is independently of the system you're using. It's not only radio frequency, also the ultrasound system has the same pain. A little bit shorter, but the same intensity.
Yes, I completely agree. If I may just add something, probably during your first cases, you may be more comfortable putting the patient through general anesthesia. It's something you may consider as you are progressing your learning curve. Like the first case, you'd be really comfortable focusing on the skills and on the technique. And once you're familiar with that, deep sedation is usually what we use. We're lucky enough to have a great anesthesiology team that we work with for the TAVI, and so they apply the same protocol with just higher dosage, but the patients come ambulatory, so they arrive in the morning, we do the procedure, we monitor them in the afternoon, and they're still discharged at the end of the day without general anesthesia. But your local resources and habits may help you find the right protocol for the right patient.
Yeah, I mean, we have nurse-led sedation, so little and often is the solution. So before you get them on the table, give them a little bit of, well, once you get them on the table, give them a little bit of midazolam, a little bit of fentanyl, and then keep topping it up during the procedure. Yeah. And it's manageable. All my patients go home as day case unless I'm forced to keep them in for research purposes.
Yeah, well, I just can confirm in Erlangen we have done over 200 procedures, and we're just doing bianalgesic sedation with different drugs for study reasons. We use midazolam because it has retrograde amnesia, and that's also very nice for the patient as well as for us.
Fantastic. I think we take 2 more questions from the room and then we'll move on. Thank you.
Excuse me, what's the difference between the procedure in the past and now? And when we expect the blood pressure will get down after the procedure, and how long its effects? When we say that the procedure was failed?
I take that? Okay, great questions. So what's the difference between procedure and now? In Symplicity HJN3, there were an average of 11 energy deliveries from the single point flex catheter between the 2 arteries, 11 between 2, so maybe 6 and 5. In Spyral off-med, the pivotal trial that led to the approval of this technology, it was 44, 45. So the new catheter is able to deliver to a broader aspect of the renal bed and therefore target nerves in more positions. And it's able to do it in a different position within the arterial tree where the nerves become closer and more accessible. So that's number 1. Number 2 is how long does it take? It's interestingly variable. Because we disconnect the communication from the brain to the kidney immediately, and yet we see most of the response late, it must be something to do with the brain no longer receiving the signals back from the kidney. So we think the brain recalibrates and changes the way that the hypertension control system works. It begins around 2 weeks. And then it completes in the majority of cases by about 2-3 months. But we are seeing signals that there's further blood pressure lowering in large data sets that may be as late as a year. So we have a non-responder rate of about a quarter. But as time goes on, some people who may have had a modest response may get a bit more of a response. In terms of how long it lasts, we have data on probably 4,000 patients out to 3 years. and then a couple of thousand out to 5 years, and it's going down and staying down if it goes down on the original procedure. And then we've got data out to 10 years now in around 250 patients. If it goes down, it stays down, and it might even be getting better.
So-called always-on effect.
So how do we know that we have clinically ablated the nerves, and how do we know what is the endpoint and how much to deliver, and how do we go about with the procedure? How many minutes to give, or whether we have really ablated it or not? How do we know the clinical, whether we are successful or not?
Yeah, we take an anatomical-based approach. We can't confirm in the lab. We've just got to denervate comprehensively both arteries outside of the parenchyma. And when we do so, we know from preclinical work there's a very high likelihood that we've disconnected the sympathetic nervous system. But that's one of many control systems for hypertension. So if the blood pressure doesn't come down, it could be that the sympathetic nervous system is not driving the high blood pressure, or the other systems are compensating. So I think now the chances of procedural failure are much lower with the spiral system than they were with the flex. With the flex, you can never be sure you've done the right job. With the spiral, we've now got a high degree of confidence that if you follow the procedures in the trials that you have, but there may be other systems driving the blood pressure back up, or the sympathetic nervous system may be a small part. Anybody else want to comment on anything?
Well, yeah, a very short comment. You have to think about the mentality of an ablation. Let's suppose you do an AFib ablation. When you decide that this has been effective, until you have recurrence, and how long you wait for that? It's at least 1 year, and you keep the patient on anticoagulation. So it's take time. It's not an immediate, it's not changing a valve. You get rid of the aortic stenosis, the patient feels great. Here you have to wait for some time before you say, okay, it has been or it has not been effective.
Each and every branches, how many minutes we have to give the impulses, or is it the continuous thing, or we wait, stop, and do it again?
The delivery of energy is always 1 minute, simultaneously in the 4 electrodes.
And then we wait for some time?
No, you move back and you give other 1 minute, and then you go back and you could add 1 minute.
Thank you.
Fantastic. So I think the questions really reflect the energy in the room to hopefully use more of this and understand more from a procedural point of view. But now that really moves us to the presentation of Valérie Duchatel, who will talk to us about how you establish a renal denervation service with a multidisciplinary team.
Thank you, Rasha, for the introduction. Dear colleagues, I'm very happy and honored to share with you today my experience in establishing a multidisciplinary hypertension team. We have had the chance to do twice here in Paris in the University Hospital of Bichat 15 years ago, and then more recently, about 10 years ago in Switzerland. These are my conflicts. So, as you know, we are facing a growing number of patients with resistant hypertension, and these patients are complicated to deal with. They have multiple comorbidities, and they often require expertise from multiple specialists, including, but not only, nephrologists, cardiologists, internal medicine specialists, endocrinologists, and so on. And we also are facing young patients with hypertension that must be screened for secondary causes. Therefore, the burden of the diagnostic workup is heavy. Now, if you try and stand from the physician's point of view, establishing true resistant hypertension requires so much time and resources, and their to-do list is extremely long. They need to rule out all the secondary causes for hypertension, requiring lab works, some of them easy to get, like creatinine serum levels, but also more advanced lab works like resting and standing renin, aldosterone, plasma catecholamines. You need to rule out obstructive sleep apnea with the sleep lab. You need to get a renal artery imaging to rule out, for example, renal artery stenosis. You need to confirm that it's truly resistant hypertension with multiple ambulant blood pressure monitoring. You need to screen for target organ damage with ECG, echocardiogram, retinal scan. And last but not least, to achieve your blood pressure goals, you have to educate your patient about meds and lifestyle. In real life, this is so long and complicated that a lot of patients are not fully tested and or educated. Now try and stand from the patient's point of view. You have to run to multiple places to do all these tests. It's complicated, it's time-consuming, and sometimes confusing as well. You have to repeat tests. Sometimes your physician doesn't get the report, so we repeat the tests again, and it relates to poor cost effectiveness. These patients also have a lot of drugs to take, and the lack of therapeutic education results in poor treatment adherence. Now, finally, when we stand in our position, we are the interventional cardiologist, and we want to denerve our patients because procedures is what we do best. But we will get better results if we have a higher volume, and for this, we need to get the patients. Who are the other hypertension experts? Nephrologists, internal medicine specialists, so we need to connect with them. The 2023 European Society guidelines emphasize that renal denervation for all of these reasons should be an expert-centered shared decision with a level 1 recommendation. Now, I'm sure you want to get to the point of how we do this. Well, you need to create somehow a win-win situation in which the general physicians will have less paperwork, your patient will access best medical care in less time, and you will build hypertension expertise and get more referrals for renal denervation. So the way you need to do this will depend on where you work. If you work in a large institution, there probably already is a multidisciplinary meeting in internal medicine or in the nephrology department that you can join and start discussing patients with resistant or complex hypertension situations. If you work in a smaller institution or if you're a private practitioner, you will have probably to build your team from scratch. And the first thing you need to do is to find at least one friend to talk to and then slowly build up your team. To get started, the first step, and probably the best, the reason our team was so successful is instead of building a whole pattern of like a journey that the patient should follow, I called every single private practitioner in the area around my hospital. It was only 15, but it still takes time. Introduce yourself and say, look, this is my plan. What would help you the most? What are your needs? What are the gaps? Is it education? Is it testing? Is it getting the reports? What can I do for you? And then this is what I would like from you is to send me patients. What tests can be done at your institution? And is there a patient's educational program already in place that you can use to teach them how to eat less salt, heart failure, or chronic kidney disease, for example? So this is an example of what the hypertension clinic looks at our hospital today. It is the regional hospital, and it is a 4-step program. It's very easy. Anyone can request the hypertension clinic. It's just an email. And then if the patient has chronic kidney disease, he'll be seen by the nephrologist, otherwise a cardiologist. First appointment, we clarify the situation and find out if we're dealing with probably resistant hypertension or a secondary cause. And then we will plan the diagnostic workup. Then the patient will come for a big education and investigation day called Hypertension Day. And we run it on the Friday of, the first Friday of every month. It's a very busy day. They got all sorts of lab works in the morning, ECG, they go to the radiology, and then they have a nurse's lecture on lifestyle and meds. In the afternoon, their partner is invited at a workshop with the dietitians to try and cook less salt, drink less alcohol, and so on. Followed is the cardiac ultrasound, and then they go home for the weekend with a funny program. They have to sleep with the sleep recorder, and they have to collect their 24-hour urine sample to calculate how much salt they actually eat. Then we discuss without the patient their situation. So we have a monthly meeting with a nice breakfast to try and motivate everyone to get up early and then continue the day in the cath lab. And then we make a concrete proposition. And the last time we see the patient is appointment number 2. And this is where we inform them of the proposition, maybe tell them about renal denervation. And very important, we return them to their referring physician. We have no intention to steal or keep these patients. We just want to help them at some stage, give some expertise, and then return them to their referring physician. Once you figure out how your ideal hypertension journey should look like for your patient, you need to advertise, and we have a great tool in our hands. We are interventional cardiologists. So we see patients every day and we write reports. So it's easy to email or call a referring physician and say, look, I just stented the LAD in your patient. But I also noticed that his blood pressure was 190, and despite several meds, why don't we just see him at the hypertension clinic and help you with this difficult situation? You can also participate in your in-hospital conferences, local conferences with general physicians or private practitioners. It could be LinkedIn posts and hospital blogs, newsletters, whatever your usual mean of communication are. You just need to get people to know what you are doing. So my last piece of advice would be to get out of the cath lab. I know it's our favorite room, but there is a world out there. So don't be shy, jump in and get started.
Thank you so much. Please come back, Valerie, and join us for the discussion.
I have something for you, but it's
right.
not. Wait for it. There you go.
Oh, wow. Thank you. Fantastic. So I'm going to, just as you find your seat, ask you one of the questions that comes up very regularly.
That's you, right?
Valerie, what do you do with your patients with renal dysfunction? What do you tolerate? What do you not? I mean, obviously, many patients with CKD were excluded from the trials.
So initially, we were very strict with the guidelines, and I have to say, as we are very confident in our results, so our threshold was traditionally the 40 millimeters per minute per meter of body surface, and then 30 came as a very safe results, and the lowest we have done in 2 patients, not just to reduce blood pressure, but also to try and preserve the kidney function a little bit and delay either renal transplantation or dialysis, has been 20 millimeters per minute, but that is off the record, obviously.
Fantastic. And then I have another follow-on question for you, if that's okay. And is it mandatory to have this fantastic multidisciplinary team approach, or do you do for people who are in centres where it's harder to put that together?
At least discussing with the colleague will bring you a lot of expertise and sharing knowledge and get some ideas. When we first started, it was just a nephrologist and I talking over coffee about the most complex patients. And then their internal medicine joined. And then it was like, well, if there's going to be 3 of us, let's have breakfast. And then let's, instead of trying to get all the reports, why don't we have a nurse trying to coordinate all that, and she will collect all the data and in a file. And then so step by step you can increase. You don't have to wait until everything is perfectly in line to get started, or you're never going to get started. So having at least one other colleague to start discussing is a great start point.
Fantastic. Now I have a question for Roland, if that's okay. The question is, from our patient groups and the subgroups we've seen in the data, are there any particular subgroups that benefit? What would you say in terms of kind of recommendations there?
Well, this is usually the $1 million question, who responds best. At the moment, I think there is only one advice, which we have seen in all studies that have been analyzed, and this is a baseline blood pressure. Meaning, if you have a high baseline blood pressure, 160, 170, or 180, the higher the blood pressure, the greater is the response, and this is, of course, beneficial for the patient. Other, let's say, predictors have been identified, all related to the sympathetic nervous system, such as high heart rate, high running concentration, or stiffer arteries on the other side. But these are not so strong that they can be used as a predictor in clinical practice. So don't measure renin, it's nonsense. Don't do that. It is confirming the whole concept, but not such a strong predictor for individual situation. And if I want just to add what Valerie just nicely outlined about the setting up a program, if you start, well, you have a good success if you start with a patient who has 170 milliliter mercury instead of with a patient who has 150 milliliter mercury, because the 170 had a greater response. The patient is convinced, your referring physician is convinced, and you are convinced.
One comment, I really want to congratulate you, because I don't see this program successful without the multidisciplinary team. And I want to ask everybody in the panel just shortly, do you also have this? Because we in Belgrade, we really established very early our hypertension center, where we really have a very big overview, and with that, we achieved to have a lot of patients in our database for resistant hypertension. Because, we are in the Congress for interventional, I'm also interventional cardiologist, but, we see those patients getting into the cath lab, doing the procedure, getting out, and then coming to the follow-up every 3, 6, 9 months just to see whether their blood pressure dropped. Me, I'm personally interested in the cardiovascular risk, because hypertension is just one of the risk factors, because what we are aiming, not just to decrease the blood pressure, but to decrease the cardiovascular risk and prevent myocardial infarction. So my question is, are we everybody have this hypertension team? And what do you think about aiming the cardiovascular risk, not just the blood pressure itself? Thank you.
That's great. Maybe we go down the panel. Andrew, please.
That hypertension day that you've set up is amazing. I'd quite like to sign up to be a patient, actually. If you can slot me in to your next one, I'll come along and do it. Global risk is important. You've got tensions within patients who come for denervation. Young patients don't want to take drugs for 30 years, but they've got low cardiovascular risk when you meet most of them. So do you offer it to younger patients to prevent them having drug side effects for 30 years? Or do you focus on the 65-year-olds with diabetes and maybe a little bit of early renal decline? You're going to get more actual risk reduction in them as opposed to relative risk reduction. But the younger patients who've got newer hypertension may respond a little bit better. We're still not quite sure on that. So I think the guidelines have said take cardiovascular risk into account. I think that's very sensible. If someone's got an annual risk of heart attack, stroke, death of 5%, then they're going to get more from a risk reduction than someone who's got 1%.
Thanks.
We have a multidisciplinary team established. I think it's necessary, it's important, and also to consider the whole concept of the patient. Just Andrew showed what are the different types of patients we are seeing and the different reaction and need to control blood pressure rapidly, or whether you can also have some time to do it. But don't forget, blood pressure needs to be controlled.
Yeah, well, I have to say that I have more the impression of the colleague from Belgrade than the impression from Valerie. I mean, we always struggle to involve non-interventionalists to send patients. It's very difficult. We tried anything, even inviting them for dinner and breakfast. They come, they eat, but they don't send the patients. They also drink. Medtronic is very generous offering drinks, and nothing happened. I have to say that what really changed was avoiding in-person meetings, and that was because of the pandemics, and we started doing online meetings. And you know what? Just by curiosity, colleagues were connecting without proposing cases, but hearing which kind of discussion, which kind of patients, which kind of screening we were doing. And so they started relying on a serious process for patient selection. And then we took the chance of showing them the results of patients that had been treated before. And after a year and a half, they started saying, well, I have a patient. I don't know what to do with these young patients because blood pressure is absolutely uncontrolled. Treat, and after 6 months, you repeat. We do these meetings regularly every month, and you give the follow-up. And you send the patient to the one who referred the patient, and they see that the blood pressure is going down. So the virtual meetings were much more effective than the in-person meetings. And you can reach people that it's also far away. We get colleagues connecting from other regions presenting cases now.
In our center, we have no patient from the nephrologist. And also today, in another session, a survey showed 0% from the nephrologist. In your opinion, what's the reason of this?
Nephrologists are usually very conservative. It's one point. And nephrologists, depending on the country or from the area where you are living, usually the patients usually don't see hypertensive patients, they see patients when the eGFR is below 30 in order to plan some kind of replacement therapy. So it depends where you are. I do not know an answer to that, but I think I want to add that with the recommendation that it should be above 40, you are on a safer side. If you go to lower, really, if you just have one case with an increase of creatinine going towards acute renal failure, it must not be complete, but a little bit, this harms the whole program. So I would really recommend to all of you who start the program, stay above 40 ml, minute per minute. The other thing is really some when you are well trained and you have done a lot of cases and you are getting more courageous, that's okay. But please not in the beginning.
Fantastic. And now we have a question for Valerie. Tell us about the learning curve. Presumably it's different for different operators, but at what point are you totally happy to be alone?
Well, I think you're lucky today because you got a great catheter. Back in the time with the single electrode, the learning curve was much longer because anytime the patient would breathe, you may lose contact and have to start all over again. Today, the procedure is really very simple. The catheter is super flexible. So apart from setting, from my point of view, the pain management is really like probably the thing that we are the most unfamiliar with as interventional cardiologists, because normally our procedures are almost pain-free. So this is probably the newer aspect. Everything else when it comes to catheter manipulation, after you've done 1 or 2 cases, you'll already be very comfortable. But if you don't do one in many months, maybe you'll be happy to have a proctor or a colleague coming in if you stop for a long period of time.
Can we do this procedure from radial access? And could we repeat the procedure for unresponsive patients?
Yes.
So 2 good questions. Radial access. So several companies in the space are working on this, and hopefully we'll have a radial catheter within about 2 years. It isn't just as simple as making it longer. The characteristics change. The second thing is, sorry, what was your second question? It's been a long day.
If you can repeat the procedure in non-responders.
Yeah, okay. Yeah, sorry, I've been up since 6 a.m. So non-responders. So there has been a case series presented by Hugh Stamen of, I think, 12 cases, where he took patients back and did them again, sometimes with a different catheter. And he showed that the response rate was similar to a naive group, i.e. around 70%. That was, though, in the days, as Valerie said, of this difficult single-point catheter. And so I think we had a medium degree of confidence about whether we'd successfully denervated at the beginning. Now, with this, if you've done 11 4-point deliveries, 44 single-point ablations, and you've comprehensively done the arterial tree, the chances of missing bits are very low. And so I think it's unlikely to work in that scenario. But we do need prospective clinical trials. I'm sure one will be done. It'll be an investigator group that will do it. And I wouldn't be surprised if there's a 20-30% response rate. But I think there's low yield. Now we've got the technologies and the techniques right.
Maybe one more comment about the radial access. When we train people, a lot of colleagues are concerned about the risk of stroke for a procedure that is elective and lowering global cardiovascular risks. So because it's not a life-threatening condition like a STEMI or an acute coronary syndrome, I'm sure some people would prefer to have a safe femoral puncture under ultrasound versus radial access. So probably it'll be nice to have both options. I'm not sure everyone will want to switch to radial access because of the small stroke risk through radial access.
Yeah, that's a very good point. It'll be 1 in 1,000 or something. And the catheters are going to be designed, I think, so you can choose. So you can choose to go via the leg or via the arm. Mm-hmm. And I think if it was a thin 70-year-old woman, I might go via the leg. If it's an obese 50-year-old guy, I'd probably go via the arm.
Yeah. And I think we're just about to wrap up, but one more kind of maybe important question that's also come up is, how do you follow up your patients, Valerie?
So we don't directly follow them for the reasons because our local habits is that private practitioners do the follow-up and they would really resent us and they would stop sending patients if we would steal them from them. But we do collect a 24-hour ambulatory blood pressure monitoring a year after the procedure, as we don't find it very relevant when we do it so soon. We'd rather see also if their salt intake has re-increased. So 1 year is usually when we have stabilized the number of drugs. We also have a clear effect of the procedure. So we don't do it too soon because you may get disappointed. Andrew emphasized on that point. Some people were called non-responders, but probably because in some of the trials we look at their blood pressure a little too soon. 3 months is a reasonable delay, but some people will start responding clearly after 6 months. And yeah.
Brilliant, thank you. It's over to you, Flavio, to wrap up. But I
Yeah.
have to thank the audience really for fantastic participation.
It has been very nice to see the enthusiasm that the therapy is rising after a difficult beginning some years ago. And very briefly, so I want to remind you that renal denervation is an FDA-approved therapy recommended by the latest European Society of Hypertension guidelines and many international and national institutes and consensus documents. Renal denervation with radiofrequency has shown safety. It was even shown in the first negative trial against efficacy in large number of studies. In over 80% of patients, they are responders, and the effect lasts more than 3 years. And last, multidisciplinary discussion for the indication on a personalized basis is essential for the success. And this is, as I said in the beginning, the most difficult part of the procedure. It's not the procedure itself, it's the organization that takes years until you convince the referrals. But of course, the best way to convince them is showing the results. So the follow-up is very important, and the feedback to the referrals is essential. Thank you very much for your attention, and enjoy your evening in Paris.